Greetings and welcome to our AIDS 2020 satellite session titled Community and Academic Partnerships to Advance Evidence-Based Policymaking, Lessons Learned from the California HIV/AIDS Policy Research Centers. My name is Ian Holloway, and I'm the Academic Principal Investigator of the Southern California HIV/AIDS Policy Research Center. I'm joined by my colleague, Wayne Steward, the Academic Principal Investigator of the Northern California HIV/AIDS Policy Research Center, and four of our community and academic colleagues, Courtney Mulhearn-Pearson of San Francisco AIDS Foundation, Craig Pulsipher of APLA Health, Dr. Naina Harawa of the University of California, Los Angeles, and Dr. Kim Kester of the University of California, San Francisco. I'd like to begin our session by thanking our funder, the California HIV/AIDS Research Program, and our program officer, Tyler Martz, who sponsored and helped organize the session. I hope many of you were able to view the pre-recorded segment of our satellite session, which described the structure of our centers, the rapid response research model, and several of our projects focused on HIV decriminalization and HIV and immigration. Today, we will build upon information presented in our pre-recorded segment and have the opportunity to present additional content on our unique model for bringing community and academic partners together to conduct high-impact research on HIV policy in the state of California. The agenda for our satellite session is listed on this slide. Before we begin, a few housekeeping issues. First, please note that we are using the Zoom webinar function, so your cameras and microphones are intentionally turned off for the duration of the session. Second, we encourage you to use the chat function from channel 1 in order to ask questions of our speakers throughout the session. Our plan is to have ample time for question and answer with our panelists at the conclusion of our session. Finally, please note that if you're not able to get your question answered during the live session, we will follow up with you via the AIDS 2020 virtual platform over the coming days. With that, we're ready to begin. It's my pleasure to introduce Courtney Mulhearn-Pearson from the San Francisco AIDS Foundation, who will be speaking on California's Ending the Epidemics initiative and ways in which our HIV/AIDS policy research centers have worked collaboratively with this important initiative. Following Courtney's presentation, we'll hear from Wayne Steward from the University of California, San Francisco, who will speak about how policy research is shaping ending the epidemics in the era of COVID-19. Thank you.
All right, well, thank you, everybody. I hope you can hear me. Welcome to our presentation, and I wish I was welcoming you live to San Francisco, but I'm glad to be joining you virtually to discuss our End the Epidemics project in California, which we're calling a Syndemic approach to ending HIV, Hepatitis C, and STDs. So just to give a little overview of what we'll be discussing, I just wanted to give a brief look at what we're considering our End the Epidemics project and why we think it's needed in California, and talk a little bit about the Syndemic approach of our project, which we think is unique, and then also talk a little bit about our accomplishments and where we're hoping to go next. California really is facing a public health crisis, which actually the COVID epidemic has laid bare, so that shouldn't have been a surprise to us, although I think it was still a little bit of a surprise. What we see in terms of HIV, for example, is while we have had significant progress in our HIV fight, we still are only seeing a 3% decline in our new HIV diagnoses between 2013 and 2017, and the racial disparities are continuing to increase. So whites actually saw new diagnoses decreasing by 13%, while Blacks only saw a 2% decline, and we actually saw an increase in our Latinx population. For HCV or hepatitis C, we have really an unchecked epidemic. We have over 400,000 people living with HIV, and 55% are unaware of their status. We're seeing nearly 34,000 new cases of chronic HCV reported, and the epidemic is getting worse among young folks, which we think is largely driven by the opioid crisis. And for STDs, we have a really unchecked epidemic as well. California is close to leading the nation in new STD cases. So compared to 10 years ago, we've seen a 265% increase in syphilis, and then similarly gonorrhea, chlamydia, and troublingly with congenital syphilis, we're really seeing an epidemic there as well, with 22 stillbirths or neonatal deaths associated with congenital syphilis in 2018. We have significant barriers in our state. We have limited funding. We saw huge HIV prevention cuts in 2009 as part of a broader statewide budget crisis. And we've only seen small reinvestments made since then. And then for hepatitis C, although California has really led in making hepatitis C treatment available, we have very, very limited funding for prevention and testing and linkage. So we know that we have the treatment here, but we can't get people to access that treatment. And federal funding for STD prevention has dropped 40% over the last 15 years. And during that time, we've seen a sort of matching increase in our STD cases. We also have really siloed state departments. So we have limited structural support for effective collaboration. And then we see social determinants of health that are really impacting all three areas. So stigma and discrimination and poverty. None of this should be a surprise, but we're really facing all of it here. These charts just show how extreme our STD crisis is in California. I think we're only second in the nation in terms of cases. And we have seen other states have HIV and hepatitis C plans implemented and seen success. So we were really inspired by the New York plan to end AIDS, which Governor Cuomo announced in 2014 and really included resources to match that. And since then, they've seen new diagnoses decline by 20%. Governor Cuomo also announced the nation's first state-level comprehensive hepatitis C elimination plan in 2018. And so with the support of our community partners, with our research partners and local health departments, we saw an opportunity to come together to really create a community consensus statement that calls on our leaders in California to launch a statewide initiative to end hepatitis C, HIV, and STDs. Really highlighting our new tools and interventions and calling for increased cross-departmental collaboration. So we both want new funding, but we also want to be more efficient with the funding that we have. So far, it's been signed by over 160 organizations and health departments across the state. And what we think is unique about our approach is that we're using the Syndemic model, which we have defined as an aggregation of two or more diseases that interact synergistically within a population. And I realize I'm running out of time, so I'll go a little more quickly. But we know that HIV, HCV, and STDs disproportionately impact many of the same communities. Having an STD, for example, increases your likelihood of acquiring HIV. HCV progresses and more than triples the risk for liver disease among people living with and co-infected with HIV, and that the similar social determinants that we talked about are driving all three epidemics. So our broader coalition goal is to urge state leaders to step up and lead by embracing an initiative to end HIV, hepatitis C, and STDs, and really driven by the research from our research partners to highlight where we're falling short and where we need new models. So just a brief timeline. In late 2017, we recognized that we had an opportunity to come together, but the political will and resources were limited. In 2018, Gavin Newsom our governor endorsed a statewide Getting to Zero initiative to reduce and hopefully eliminate HIV and HCV. And we've been working together as a collaborative ever since to try to make that promise realized. We have had some, we also formed an advocacy coalition separate from this group to help make sure that the resources were available to fund this effort. And we've had some modest successes, but that progress has been stalled largely due to the budget crisis our state is now facing due to COVID. And again, COVID is exacerbating the health inequities that we already knew existed. And it's hardest hitting the populations that are most disproportionately impacted by HIV, HCV, and STDs. So very briefly, our next steps are, in the context of COVID, we need to develop a new strategy to move forward. We also recognize that we need to do more work around developing our racial justice framework. So we're focusing on integrating racial justice into our mission and value statement. We're forming a coalition to make sure that we're really doing the best we can to address systemic racism in HIV, HCV, and STD, and also developing a process for how we can monitor our work on an ongoing basis to ensure that anti-racism is centered in our coalition priorities. And we're also continuing to work with the California HIV research program to help make sure that we're really targeting the policy research where it can be most helpful. So thank you very much, and I apologize for going over, but I'm really glad to see you all and look forward to the discussion.
Hello, it's good to be with everyone today. I was introduced a little while ago, but I'll just note who I am again. I'm Wayne Steward. I'm the academic principal investigator for the Northern California HIV/AIDS Policy Research Center, and I'm a professor at the Center for AIDS Prevention Studies at the University of California, San Francisco. The study that I'm going to describe is going to be the first of the examples we're going to feature today of rapid response research. In this case, it was a study that the two policy centers conducted jointly to understand how the COVID-19 pandemic was affecting the delivery of HIV, hepatitis C, and sexually transmitted infection services at community-based organizations in California. And this particular work emerged from the larger Ending the Epidemics initiative that Courtney was just telling you about a few moments ago. Before I jump into those details, let me just note that I do not have any disclosures or conflicts of interest to note. And I would just like to acknowledge the following individuals whose names are listed here on the slide. So the need to understand the potential impact of COVID-19 on HIV, HCV, and STI services was motivated by several considerations. The most obvious of these would, of course, be the shelter-in-place orders that were enacted here in California to discourage people from leaving their homes for most purposes. The lockdown meant the loss of usual revenues for community-based organizations, plus challenges rendering services that would normally be delivered in person. At a policy level, these realities were then paired against an anticipated state budget crisis that left open the possibility of funding cuts, plus a loss of revenue to help support struggling agencies. So we developed, in order to look into this situation, we developed an online survey that was distributed to CBOs. Academic and community partners at both of the centers worked together, with the community partners helping to inform the content of the survey, while the research partners designed and programmed the survey tool itself. Our partners within the state government were also interested in what the survey might show, and as a result of that, California State Office of AIDS agreed to distribute the link to the survey to all of the organizations that it had in its contacts list. In addition, our community partners within the two centers were able to distribute links to the survey to their professional contacts within the state. Once we had collected the data, we ultimately ended up having 70 unique CBOs complete the survey. They were distributed across California, and they varied in size from smaller to larger organizations. Most received funding through the U.S. Ryan White HIV/AIDS program. A majority provided HIV and/or STI services, and a smaller percentage supported HCV services. As reflected on the slide, the agencies served a wide variety of clients that are reflective of the communities here in California that are at risk of HIV, HCV, or STIs. So this slide here, that should now be up on the screen, shows you that one of the principal changes that the organizations reported was a strong increase in demand for a number of different services. Particularly pronounced were the need for food, housing, and social support services, along with direct financial assistance. This is not necessarily surprising given the known impacts that COVID-19 is having on individuals. At the same time, respondents also reported substantive impacts on their ability to render services. Consistent with the shelter-in-place guidelines, most had employees working at home, and a majority had modified their service hours. Smaller percentages reported furloughing or laying off employees. The limitations caused by the shelter-in-place requirements resulted in yet another set of services being reduced or temporarily suspended, as depicted on the slide now showing. You will note that HIV, HCV, and STI testing were all particularly affected. That's likely in part because those services had previously been conducted principally through on-site appointments. In addition, outreach efforts were also reduced, this being due to the inability of staff to utilize typical strategies like street or venue-based outreach. And I would like to also highlight that there's an arrow on here reflecting a reduction in medical services. This may seem like a counterintuitive finding given that we're in the middle of a pandemic. We collected some open-ended responses from participants as part of the survey, and what those responses suggested is that the reduction for these agencies was often caused by their inability to obtain sufficient personal protective equipment to make in-person services safe, and in a few cases by licensing complications that were created by the fact that we were surveying respondents that were community-based organizations and not medical facilities. 2/3 of the responding agencies anticipated that they would have substantive funding gaps as a result of the limitations caused by COVID-19. I should note that this was a need that they stated they would have after accounting for any supplemental or emergency funding to which they had applied. On average, there was a $1.3 million need per agency, and across all of our respondents, it summed up to a $49 million reported need. If left unaddressed, agencies said that they expected a variety of consequences ranging from furloughs and layoffs to permanent closure. After we finished collecting and analyzing these data, we summarized the findings in a one-page, easy-to-digest infographic, which our community partners distributed to lawmakers and policy stakeholders who are working around the state on California's annual budget. The final budget deal, which was recently passed into law, preserved and extended an annual $5 million per year appropriation for prevention activities for each of the three conditions, that would be HIV, HCV, and STIs, or $15 million in total per year across the three conditions. It should be noted that this extension was approved despite California's record budget deficit. It doesn't take care of the full $50 million need reported in the survey, but the appropriation does help to ensure that agencies do not face further shortfalls as a result of the state withdrawing additional funds. So I would like to thank you for your time. I'm just noting here that you can find a copy of the survey at the link that's on the screen, and I will be happy to answer questions later in the session during the Q&A. Thank you.
Thank you, Courtney and Wayne. Our next set of panelists are going to speak about our center's work on HIV pre-exposure prophylaxis implementation in California. PrEP is one of the key components of California's Ending the Epidemics work, and research on policy to support PrEP implementation has been part of our center's work since 2013. Our next speaker, Craig Pulsipher from APLA Health, will be speaking on innovative responses to increasing PrEP access and uptake in California. Then Dr. Naina Harawa from UCLA will speak about leveraging public data to understand PrEP uptake. And finally, Kim Kester from UCSF will speak about attitudes and community pharmacy access to HIV prevention medications in California. Thank you.
Good morning from Los Angeles. As Ian said, my name is Craig Pulsipher. I'm the Associate Director of Government Affairs at APLA Health. Today I'll be talking about some of the center's PrEP research and its impact on PrEP policy in California. So before we begin, I just want to talk a little bit about what PrEP uptake looks like in California. So we currently have about 27,000 PrEP users. This is data from 2018 that was provided by AIDSView. This is the best data source that we have at the moment for overall PrEP uptake, but important to note that this is an underestimate and does not include closed healthcare systems like Kaiser Permanente, which accounts for a large number of PrEP users in the state. Important to note that a significant portion of PrEP users are concentrated in urban areas, so about 50% of people taking PrEP in California are in Los Angeles and San Francisco. According to the CDC, PrEP coverage in the state is about 22%, and so according to the CDC, about 22% of people who could benefit from PrEP are actually taking it, and so there's certainly a lot of work to do to achieve broad PrEP coverage in the state. And important to note, my colleague Naina Harawa will go into this a little bit later in the presentation, but just want to highlight that, we have seen significant increases in PrEP use across California since it was first approved, but we do continue to see significant disparities by age, gender, and race. So importantly, PrEP uptake remains extremely low among populations most impacted by HIV, in particular Black and Latinx gay and bisexual men, women, including transgender women, and young people. The state's goal is to have 60,000 PrEP users by 2021, with an explicit focus on equity, on ensuring that we're reducing and eliminating those disparities that I mentioned earlier. So the center's first PrEP study was actually in 2015. We did an online survey of over 600 young gay and bisexual men. Everyone was between 18 and 29 years old. About 40% of the sample was Latinx, 32% Black, and about 27% white. And this was the first statewide survey of PrEP awareness and use, likelihood of use, as well as various attitudes and perceived barriers to PrEP uptake. So there had certainly by this time been a number of studies looking at these issues, but this was really the first study that took a statewide look at California. So just giving you a brief highlight of the results, the report is much more extensive, but overall the research documented a strong interest in PrEP, but there was limited knowledge and many concerns. So about 90% said that taking PrEP would be a good way to protect themselves from getting HIV. This was slightly lower among Black respondents. And about 60% say they did not know where to access PrEP. They would not be able to afford PrEP, and they were concerned about side effects. And importantly, younger people were significantly more likely to be concerned about family members finding out that they were taking PrEP. So in addition to this research, the center actually hosted a number of community meetings to help further identify policy and funding priorities over the subsequent years. So next, just want to talk about some of the policy implications of the research and these community meetings that the center hosted. First, the state has significantly increased funding for PrEP education and navigation, which is a crucial component of increasing PrEP uptake. Over the last several years, the state has allocated $10 million for HIV prevention, and a significant portion of that has gone to PrEP education and navigation. And important that this funding really focuses on addressing those inequities and addressing the barriers, including stigma, medical mistrust, and other barriers to PrEP and HIV prevention. A really key component of the state's PrEP response has been the statewide PrEP assistance program. This program was launched in 2018, and it covers all PrEP out-of-pocket costs for both insured and uninsured folks earning less than 500% of the federal poverty level, which is about $64,000 a year. And just want to highlight a couple of key pieces of this program which I think are really important to increasing PrEP uptake. One is the confidentiality protections. So we know that youth have concerns about potentially family and friends finding out. And so minors under 18 and individuals who are insured on a parent or partner's plan do not need to use their insurance, and they can have all of the costs covered through the state PrEP assistance program. Another exciting development is just a couple weeks ago, the state was authorized to provide 30 days of PrEP and PEP, regardless of whether they're eligible for the program. And so we're still working through the details of how this is going to be implemented, but we're hopeful that this will help support same-day initiation, which we know from New York and other jurisdictions is really critical to increasing PrEP uptake. And then we also have an online directory of providers and enrollment sites, and there is a telehealth option, which has become even more important in light of COVID-19. And then lastly, just want to highlight some of the legislation that has come from this research and the community meeting sponsored by the center. In 2016, the legislature passed legislation that requires information about PrEP and PEP to be provided to individuals who are HIV negative after they receive an HIV test. So this is now in state law. So anyone in California who receives an HIV test from a primary care provider or in another setting is required to receive this information. And just last year, the state passed first of its kind legislation that allows pharmacists to provide PrEP and PEP without a doctor's prescription and prohibits insurance prior authorization requirements for these medications. My colleague Kim Kester will talk more about the pharmacy piece of this bill later in the presentation, but just want to highlight the prior authorization piece that the center did do some research looking at the impact of prior authorization requirements. We spoke with PrEP navigators and medical providers, and they really demonstrated what we had been hearing for a long time, is that prior authorization can result in dangerous delays in patients' initial and continued access to medication. So lastly, just want to stress that PrEP uptake in California remains low. We continue to have disparities in uptake, and so additional research is going to be needed to look at the impact of these recent programs and legislation, especially the impact on equity. And certainly ongoing research and policy change is going to be needed to address other issues that we know have an impact on PrEP access, particularly stigma and systemic racism in our healthcare system and in the US more broadly. So I'll stop there and looking forward to questions later.
Good morning. My name is Naina Harawa. I'm a professor at David Geffen School of Medicine and a co-investigator with the California HIV/AIDS Policy Research Center in Southern California. I'm talking today about how we can leverage public data to understand PrEP uptake and to share a little bit about what we've learned in that process. To add a little bit to the background that Craig Pulsipher just shared, we know that there are racial and ethnic disparities in PrEP uptake across the board, but especially for men who have sex with men, who make up the largest proportion of cases in California and much of the US. We also know that there are disparities in uptake by health insurance, and that because of this, we wanted to look at our data at a population that all had access and had a uniform type of access to PrEP. And these disparities in terms of PrEP uptake are in a background of disparities that have been observed related to HIV incidence, with highest incidence among younger people and increasing incidence among young men who have sex with men, greater impact of HIV among Blacks and Latinos compared to other race ethnicities, and highest HIV prevalence in sexual and gender minorities and in women of color. So as I said in our recent efforts to look at PrEP uptake in California, we focused in on publicly insured adults. And those are people who have Medicaid, which is public insurance in the US, and in California, it's called Medi-Cal. You can see on the right hand of the slide in the sort of most green triangle, I guess they're all a different shade of green or blue, that comprises 16% of the population. So based on these data, we were able to look at both rates and numbers of PrEP beneficiaries on, Medi-Cal beneficiaries who had PrEP prescriptions over time. And you can see that in terms of numbers here, mapped against key events in terms of rollout of PrEP in California. So we see FDA approval in 2012, second half of 2012, efforts that were launched by the San Francisco AIDS Foundation and later Project Inform and University of California, San Francisco to increase access and knowledge of PrEP, clinical practice guidelines, and later the passage of AB 2640 that Craig talked about and that required high-risk people who were tested for HIV to receive information on PrEP. And the short of this story is that PrEP uptake did increase among beneficiaries across this time. But I want to dig in a little deeper to show you a little bit what that looks like. Just in summary, what we've seen in the data is that a much sharper rise was observed in men than in women, that the fastest rise were in those 25 to 44 and the slowest rise in the youngest and oldest age groups of Medi-Cal beneficiaries. Much steeper rises were observed in urban areas and over time, slower and possibly leveling rises in rural areas. And in terms of the counties that had the three highest incidence rates of new infections, San Francisco had the strongest and sharpest rise. Much slower increases in PrEP uptake have been observed in Los Angeles and San Diego counties. And then when we look at racial and ethnic groups across the board, we see the sharpest and highest overall uptake in whites and those who identify with other race ethnicities, and the lowest overall uptake in Hispanics. And there's 2 reports on our website with more of these details. I'm going to focus in more specifically on what we see in terms of race ethnicity among male beneficiaries. And so on the left side, you can see those numbers in terms of PrEP uptake over time within each racial and ethnic group of beneficiaries for Medi-Cal, male beneficiaries. Right side, you can see that in a different way, just pictured as the percentage of Medi-Cal beneficiaries on PrEP by race ethnicity. And we do see an increasing proportion of beneficiaries who are Hispanic, but this in no way represents their representation among the Medi-Cal population or the California population. And here's the backdrop of what HIV itself looks like among men who have sex with men in California. By far, the highest rates are among Blacks, but next highest are among Latinos. And if you see on the right, these are new diagnoses over time. You see a troubling sort of pattern of increase among Latinx men who have sex with men, kind of in a backdrop of declines in many of the other racial and ethnic groups. So this is my last slide, but it's a little, or second to last slide is a little complicated. So I'll just try to paint the picture. We were able to use these data for 2018 to calculate age-adjusted estimates of unique PrEP users and the percentage of each racial and ethnic group and gender group who were on PrEP in Medi-Cal. But of course, these overall percentages of people on PrEP don't tell us about the most important group, which is those who are at elevated risk and actually have an indication for PrEP. So we were able to try to get a better look at that by looking at what is the percentage of each racial and ethnic group and gender group who report elevated risk from HIV from a public use data set called the Behavioral Risk Factor Surveillance Survey. And you can see those range from 5 to 12%. And then use those 2 estimates to get a rough estimate of percent uptake among those at risk. And the short story of this is that uptake remains low and that it's highest among non-Hispanic white men and lowest among, in terms of among men, it's highest among non-Hispanic white men and lowest among Hispanic men. So I just want to kind of summarize with limitations and opportunities. Triangulating these data can help illuminate rates of uptake, but they also, each of these data sets have limitations. So the healthcare utilization data that we have lacks information on risk factors. We only have information on sociodemographics. The HIV surveillance data we have are not limited to Medicaid beneficiaries, and the population-based survey data like the BRFS are not limited to key populations like sexual and gender minorities. So in some ways, they overestimate the population that's at highest risk for PrEP. But we can summarize all of these data by saying that however you look at it, there's suboptimal uptake. There are gender and racial disparities that certainly warrant our concern, and a continued approach like that we've presented earlier by Craig and Courtney. Thank you.
Good morning, everyone. My name is Kimberly Kester, and I'm coming to you this morning from San Francisco. I'm an assistant professor at the University of California, San Francisco, and a co-investigator with the team in the Northern California California HIV AIDS Policy Research Center. And I want to start my presentation by saying thank you to all the panelists. It's fun to go last. And although we do meet with each other regularly, we don't always hear about one another's findings. So thank you all for your rich presentations. I'm going to be talking today about a study we did to give you the findings on the attitudes about community pharmacy access to HIV prevention medications in California. And I think we're well set up to understand the background of PrEP use in our state. I'll tell you a little bit more. So increasing access both to pre and post-exposure prophylaxis is a high priority really all over the world, particularly though in the United States and in California. Expanding access to these medications through community pharmacies or retail-based pharmacies might be one way to increase uptake. And as Craig Pulsipher, my colleague in Southern California, just briefly mentioned, California is the first state in the United States to allow community pharmacists to offer pre-exposure and post-exposure prophylaxis without a prescription, which is very exciting. Let me tell you a little bit about the piece of legislation that allowed this. This is California Senate Bill 159. Craig talked to you a little bit about this. I'm not going to go into the details about the prior authorization, but I will focus on the other components of the law, which allow pharmacists to furnish HIV, PEP, and PrEP without a prescription. Pharmacists are allowed to furnish a full course of PrEP, PEP, and up to a 60-day supply of PrEP, no more than once every 2 years. So this is an important caveat here. A 60-day supply of PrEP, no more than once every 2 years, and a full course of PEP. Pharmacists who are interested in participating in this program do undergo an improved training, and this law just took effect last week, July 1st. So our rapid response project, which was developed in partnership with our community partners, so thank you to Craig and Courtney for your help with our qualitative case study. We conducted this research focused on key stakeholders, including pharmacists, medical providers, and representatives of large retail chain pharmacy. It's a small qualitative case study. We spoke to 12 individuals, and these folks were working in either the Bay Area or in Southern California. We conducted semi-structured phone interviews that were recorded and professionally transcribed. And we reviewed those cases for similarities and differences. So basically conducted a thematic analysis. And in our the study is very much focused on the acceptability and feasibility of the proposed legislation. We conducted this research while the legislation was being crafted and changing. Honestly, the language was changing as we were conducting the research. So we were really trying to understand, to what degree is this legislation acceptable and feasible to allow community pharmacists to furnish these HIV prevention medications. So I have 2 slides to tell you about first the benefits and then some of the challenges with the legislation, the benefits of SB 159. So our key informants overall stated that, the legislation was sensible. It really did make sense. Community pharmacists, first and foremost, there's a strong perception, widespread perception that they are indeed more accessible than traditional PEP or PrEP providers. So in the United States and in California, PEP can be accessed through a primary care provider, but more often people are accessing emergency departments or urgent care clinics. So entering a pharmacy much more accessible for both PEP and PrEP. Furthermore, the legislation is sensible because it really builds on precedent in California for other kinds of prescription medications that pharmacists are allowed to dispense without a prescription, and these include naloxone, some versions of oral birth control, and smoking cessation medications, among a few others. And a few folks pointed out that with involving pharmacists, that we could potentially create greater efficiencies in our healthcare workforce. So in different parts of the United States, and certainly in California, there are extreme healthcare workforce shortages among primary care providers. There could be some room for efficiencies by involving pharmacists to dispense PEP and PrEP. And I will note here that in particular, our interviewees perceived PEP as being a very good fit for pharmacy access. There's more criticism, which I'll get into in a moment, about PrEP access. So in terms of implementation challenges, first, the pharmacy environment was perceived to perhaps be, not private enough to have the conversations that would be necessary for a consumer to approach a pharmacist to seek PEP or PrEP. Pharmacists were also perceived to potentially be too busy to offer this service. I would say the questions really were very much focused on the infrastructure within pharmacies that were of concern, that in order to facilitate implementation, these things really needed to be addressed, and they include lack of a system to order labs for the baseline labs for PrEP, lack of a reimbursement structure. So while pharmacies could recoup monies for the drugs themselves, for the service of counseling would not be reimbursable, at least at the moment, and that was a real concern. And then with regard to the 60-day limit on PrEP, it was understood that pharmacists would hand off their PrEP consumers to a local primary care provider for ongoing PrEP care, and there's no real systematic care coordination to do this, so that was considered to be a real challenge. And then finally, medical providers in particular thought that there may be missed opportunities to diagnose and treat other health conditions, and so that dampened their enthusiasm for pharmacy access. So a quick summary. Pharmacists delivered PEP and PrEP was theoretically acceptable to our interviewees. It may be an easy entry point to PEP and PrEP access. It may bridge individuals into ongoing PrEP care. However, concerns about the feasibility in the real world implementation, again, really limited how people could think about, the degree to which this piece of law, this piece of legislation could really move the needle in increasing access. And in particular, there's agreement among our interviewees that some individuals would really benefit from ongoing pharmacist-delivered PrEP, and that 60-day limit would be insufficient and potentially harmful. So implementation research on the rollout and the identification of resolutions to the challenges and measurement of uptake is needed, and we're hoping to carry out some of that research in our Northern Policy Center with help from our Southern California site as well. Questions to evaluate the policy implications include, are pharmacists coming forward to participate? This is an opt-in program, so we will need pharmacists to come forward, and the degree to which they are coming forward is yet not known. How will the challenges that our interviewees raised associated with labs, reimbursement, and referral to primary care providers be handled? We very much want to know how the 60-day limit of PrEP will work out in real life. For some folks, it could be enough time to bridge to a primary care provider, and others, not at all. Finally, the real key question here is, will the implementation of SB 159 be associated with an increase in PrEP and PEP use across the state? The gap that Craig pointed out, there's a significant gap. 22% of eligible PrEP users are actually using PrEP. We have a long way to go. And if this does seem to increase uptake, we will look to see for whom the access point appeals to and why. So thank you for your attention. We're going to move to question and answers. Thank you so much. In particular, shout out to our funder, the California HIV/AIDS Research Program. Thank you.
Thank you, Craig, Naina, and Kimberly. Now we'll move into the question and answer section of our satellite session. I apologize to those of you who are trying to use the chat function via channel 1, which seems to be having some technical difficulties. Fortunately, we've been able to log several questions via Twitter. And so at this point, we welcome additional questions from anyone who's attending live via our Twitter, which is at CA_HIV_policy_RC. I'll be reading questions from our satellite session attendees, and we'll get started. So one of the first questions we received was for the folks working on the Ending the Epidemics Coalition, Craig, Courtney, and others. What were the challenges in building coalition across movements? The questioner notes that HIV advocates often work in a siloed environment. So again, what were the challenges in building coalition across movements, and how did the research of the policy centers inform that work?
Sorry, can you hear me?
Yes.
Okay. So I agree. I think the challenges we saw were that HIV advocates, as noted, do work in a bit of a silo. As an HIV advocate, I can say that. We also found that HCV in particular advocacy was not as well funded. So not many organizations have a dedicated hepatitis C advocacy position. And so it was harder to kind of bring that voice to the table in an equal way. And similarly for STDs, I think we have some really great STD advocacy organizations, but certainly not the number of STD advocates alone. But I think we've actually seen a lot of success in this area, and we're getting better as we, specifically on the advocacy side, we built an advocacy coalition. And I think this year, we're really starting to gel in terms of how we all talk about each other's issues and highlight a lot of each other's issues. And I would just also say that many of our organizations, while we may have historically done HIV advocacy, we're not only treating HIV anymore. So a lot of those issues are coming up naturally for HIV advocates, as well as we broaden our scope to become more HCV and STD focused. So I don't have a great answer to that, except that it's a learning process and one that we're continuing to kind of iterate on. And that I think this year, probably, what are we, like 2.5 years into being an advocacy, or about 2 years into being an advocacy coalition, I think we're kind of finding a common voice and really being able to address the syndemics. And then remind me the second question, or Craig, I don't know if you want to.
Yeah, Courtney or Craig, how has the work of the Policy Research Centers supported that coalition building?
Yeah, so we've had to shift, right, in our focus. The center is funded to do HIV policy research, and so we've kind of had to shift how we think about the policy research we're doing as well. But I think Wayne's example was a really good one, that recognizing that none of these issues exist in a silo, and so really needing to kind of step back and look at it from a syndemics approach, and that we were, I think, with the COVID study, able to do that really effectively, and to reach a broader group using other tools like the Office of AIDS listserv, which reaches a broader audience than what we had access to traditionally through our CHRP centers. So it's, again, not a final answer, but it's where we're moving in that direction.
Excellent. Craig, anything to add before we move to the next question?
Yeah. I mean, I think the only thing I would add is the center's role as a convener. I mean, certainly bringing together different movements and folks who I think all have the same goal, but sometimes different interests and different concerns. And the center has played a really important role in terms of bringing people together and identifying common priorities and helping kind of build out this statewide movement. So the center's role as a convener has been really critical.
Excellent. The next question is for the folks who are working on PrEP. So Naina, Kim, and Craig, is there a way to tell if PEP, post-exposure prophylaxis uptake, leads to PrEP uptake, and ways that, if it does, policy might leverage that connection?
That's a great question. We don't have it in the data that I've worked with. I don't know if Kim or others have that kind of data.
It is a really interesting question, and thanks for asking that. One thing that I have seen in a PrEP project we did in Oakland, California, was that people who sought PrEP were actually eligible for PEP first. So it worked in sort of the opposite direction. So someone who was seeking PrEP and not PEP were actually started on PEP and then shifted to PrEP.
Very interesting. Craig, did you want to add?
Yeah, I mean, I haven't seen good data on this as well. I think anecdotal evidence would suggest that PEP is a good gateway toward PrEP. And I think we've certainly heard a lot of people who might access PEP and then once they meet with a primary care provider, transition to PrEP. But I have not seen good data, at least in California, on that.
Okay, excellent. The next question is for Naina. So PrEP uptake and Black and Latino women, what's the story in California? Any data you can provide on that?
One of the things that is interesting about that is that I guess the good part of the story is that it tracks more with the disparities that we see in rates of infection. So we see the highest rates of infection among women in Black women, and we see the highest rates of PrEP uptake in Black women, at least among Medi-Cal beneficiaries. So at least there we don't see the disparity in uptake, but uptake is still overall very low. And you could see even, among our best estimate for the proportion of Medi-Cal beneficiaries who are at risk for HIV or at elevated risk for HIV, fewer than 1% of women across the board were on PrEP.
Okay, I think we may have time for one more quick question. This one for Wayne or others who worked on the COVID-19 organizational survey. What do you see as the next steps to building on that work? Anything planned?
So we are going to actually follow up with some of the organizations to do a little bit more of a qualitative inquiry. There were some organizations that had very unique needs that were not well represented when you cut across a lot of organizations. For example, ones that work with incarcerated populations.